coordination with Dr. Glazier and Dr. Winokur. So we're back on track, though, so that's great. So I'd like to take this opportunity to welcome you back from your session. I hope you all had an opportunity to visit some of the vendors. Who has new jewelry on? Raise your hand. All right, sir. I like that. Well, our next presenter is Dr. Esteban Lopez. He is going to give us a much-needed update on the Affordable Care Act and Medicare issues. Dr. Lopez serves as the regional president at Blue Cross Blue Shield of Texas, where he oversees the engagement in major metropolitan areas such as San Antonio, Austin, Laredo, El Paso, and the Rio Grande Valley. Dr. Lopez has also worked as a practicing physician with nearly every hospital system here in San Antonio and is a dual board certified in both internal medicine and pediatrics. That's a wide scope of service, isn't it? Okay. He holds a degree from the University of California at Santa Cruz and Michigan State University from the College of Human Medicine, in addition to a master's in business administration from a combined program at UT Dallas and UT Southwestern School of Medicine. So please help me welcome Dr. Lopez.
Good. Is this on? This is on, right? I'll probably stay here for a minute if I decide to get off stage. I realize that it's a great group here today, so thank you so much for having me. As the regional president for Blue Cross Blue Shield of Texas, of course the Affordable Care Act is an important part of the work that we do. We're the only insurance company that's in all 254 counties in the state of Texas with regards to the Affordable Care Act, and so we're very proud to be able to do that for the state of Texas. So before we get started, though, let me get an idea of who's in the room. Raise of hands of healthcare professionals. Great. Social workers, specifically? Great. Case managers? Physicians? Couple. I heard there was a dentist in the room somewhere. All right. And then nurses? All right. So a lot of nurses may be case managers or involved in social work as well. Well, great. So the Affordable Care Act, as we know, came to fruition with the opening of open enrollment on October 1st of 2013, and we all are aware that there were some challenges with that open enrollment. The state of Texas did not create its own marketplace or exchange, so we were reliant on the healthcare marketplace at the federal level. Things got a little bit better towards December and then really took off in the first quarter of this year. I'm going to start off by giving you a little bit of a snapshot in terms of some demographic information. And I apologize if you've already seen some of this information. I haven't had the privilege to be at your entire conference. But then we'll talk a little bit about the Medicare space and then the Affordable Care Act and how it relates to that space. Additionally, Jessica is manning our booth, our table here today, and so if you want specific information with regards to Medicare, we can provide that as well. So, a snapshot of San Antonio in comparison to Texas. So, roughly in the San Antonio metropolitan area in 2013, 1.4 million residents. In Texas, we're looking at about 26 million. The population percentage change in San Antonio increased in comparison to the state of Texas. And I understand that folks in the back of the room may have some challenges viewing the slides. As we move forward, I'll do my best to try to explain them. So in San Antonio, the percentage increase was about 6.1% versus the state of Texas 5.2%. However, the persons 65 years and over by percentage in around 2010, San Antonio was comparable to the rest of the state of Texas, roughly at about 10%, and we're still looking, around that area now. Veterans in San Antonio, 108,000. In Texas, 1.6 million, and we know that our veteran population is very important to us here in the San Antonio community. Just for point of reference, I live here in San Antonio. I actually live almost a block away. It took me 3 minutes to get here from my home, and I'm a practicing physician still in the San Antonio community. Persons below poverty level, unfortunately in San Antonio, we're an outlier in comparison to the state of Texas. We're roughly about 20% here in San Antonio and 17% across the state of Texas. Medicare-specific stats, 50% of folks in Medicare in 2013 had less than $23,000 in income on a per-person basis. So level setting in terms of the amount of money folks in Medicare are making, the large percentage of folks in Medicare are not making a whole lot of money. And if we broke that down into specific ethnic groups, then those numbers would change, specifically around our Latino population and our African American population. So that's around 52.4 million Medicare beneficiaries. The projected growth in Medicare per capita income between 2013 and 2030 is also going to increase just a couple of $1,000s, which is not a significant increase. So we established that $23,500 in 2013, and in 2030 it's going to be about $28,000. So we don't expect that folks in Medicare are going to be making a whole lot more money in the years to come. As we look at per capita savings of total Medicare population by race and ethnicity, now this is not income, this is savings. How much do folks save? The average for all beneficiaries is around $61,000. For white or Anglo population, it's around $89,000 to $90,000. We look at our African American population, it's about $10,000, $10,300, and about $1,000 less in the Latino population, so $9,300. So here in San Antonio, where our population is roughly 64% Latino, very significant realities in terms of how much folks have saved, and this clearly affects how much they can contribute to their health care. There are a few animations here. So the Affordable Care Act. This is a survey by the Kaiser Family Foundation from 2011. So trying to establish an understanding of beliefs around the Affordable Care Act and provisions that were in place. It started in February 2011, and the latest was in January 2014, and these are year over year. So in terms of, there was a little bit more understanding in terms of most provisions in January of 2014 versus February 2011, but even in March of 2012, the understanding had gone down significantly. What we're trying to point out here with this slide is that there really hasn't been a significant increase. So a lot of folks still understand some provisions, not enough understand most of the provisions, and a generous amount of folks just don't know. And so as we look at the number of folks that understand all of its provisions, that number did not change significantly. We were about 3% in February 2011 and 3% in January 2014. So an understanding of the Affordable Care Act, while we see that folks have gotten a little bit more of understanding between 2011 and 2014, it hasn't been a critical large number of individuals. We'll go through some individual stats. So to the best of your knowledge, would you say that healthcare reform law does or does not, yes, law does this, or no, it does not? So require nearly all Americans to have health insurance or else pay a fine. 81% said yes, 19% said no. Provide financial help to low and moderate income Americans who don't get insurance through their jobs to help them purchase coverage. 63% said yes, 38% said no. Prohibit insurance companies from denying coverage because of a person's medical history. 54% said yes, and 46% said no. So this is striking to me, especially this bottom part. So clearly, the idea that pre-existing conditions are not something that insurance companies, such as my own, can look at to determine someone's eligibility for insurance is an important part of the law. But roughly half of the percentage of the population surveyed were not aware that that was in the law. Does the Affordable Care Act require nearly all Americans to have insurance or else pay a fine? 79% said yes, 22% no. Provide financial help to low and moderate, 54 yes, 46 no. Prohibit insurance companies, so we already saw that one. Awareness of ACA in terms of, this is just a different graphical representation in terms of how folks who had understood that health insurance was required, it was pretty high. ACA provides financial assistance, it's somewhere in the middle, and then ACA prohibits denying coverage based on pre-existing conditions, not really where we would want it to be, either for the total public or the uninsured, specifically less than 65. So folks that would specifically benefit from this law, while the Medicare population has some benefits around it, really the law is targeted to folks under the age of 65 and still not necessarily having all the information that they need with regards to ACA. So where are we now? We talked about the fact that October 1st of 2013, we hit somewhat of a rough patch. However, it looks like we've made up for that. So the projections nationwide were that 7 million folks would sign up. We have over 8 million folks thus far signed up for the law, or for the insurance. 2.2 million of the people who selected a marketplace plan during the initial open enrollment period were young adults between the ages of 18 and 34. Why is that important? What we call that population is the young invincibles. Typically, this population of folks would opt out of insurance, but as you indemnify an entire nation, and really the only thing that determines the cost of your insurance plan now is your age and your zip code, not even your gender, then we needed that population to be able to sign up, and 28% is a decent number. Nearly 3.8 million people selected a marketplace plan during the March enrollment, and meaning the month of March, the last month of open enrollment. Again, not super surprising. Americans, we tend to procrastinate, especially men. I mean, I purchased my Christmas gifts on December 24th. So we have experience around this from Massachusetts. When they had their plan, the bulk of those folks signed up in the last month. And so as we go through the enrollment season, and last year we had a 6-month enrollment season. This year we're going to have a 3-month enrollment season. So it was longer last year because it was the first enrollment season. Folks are going to have less time this year. And if you purchased insurance last year, you're going to have to re-sign up. So it's important for folks to be able to understand that. So marketplace eligibility and plan selection. So we have some Texas information here versus the rest of the United States. So in Texas, we determined that 1.3 million folks were eligible to enroll in a marketplace plan. And this is eligibility determinations based through April 19th of 2014. So people could still sign up through special enrollment period. 835,000 folks were determined eligible for financial assistance. 140,000 roughly were determined eligible for Medicaid or CHIP. And then 733,000 actually signed up for a plan. So what this is telling you is that essentially 1.3 million folks in Texas went to the healthcare marketplace. Not all of them signed up. 733,000 actually bought a plan, and 140,000 went to Medicaid or CHIP. And so we have in the state of Texas, where we had 6.2 million uninsured, and 60% of those uninsured roughly were Latinos. So have still some work to do in terms of getting the bulk of our population in the state of Texas insured. In terms of the United States as a total, numbers were 13.5 million went to the marketplace to determine eligibility. From that 13.5 million, 8 million actually purchased the plan. The plans selected, by and large, were the silver plans. And if you're not familiar with the plans, I'll quickly give you a primer on it. So there were bronze, silver, and gold plans. The silver plan is essentially a 70-30 plan. So you have about a 30% out-of-pocket expense versus your insurance covers about 70%. The gold is what a lot of folks know as an 80-20 plan, and then the bronze was essentially a 60-40 plan. The reason why the silver was the most popular is that your benefits in terms of your subsidy and limits in out-of-pocket expenses were occurred most if you had a silver plan. And so, and your subsidy was actually based on the second lowest silver plan in your region. So, for instance, you know, if X insurance company is offering a silver plan and they're the second lowest, your premium is going to be based off of that, or your subsidy is going to be based off of that premium. And so you actually got a bigger subsidy. If you ended up buying the lowest cost silver in your region, it covered the majority of your premium oftentimes. And we had folks that were paying, you know, 5-cent premiums, $5 premiums, $20 premiums, depending on what percentage of poverty they were at. So as you may be aware, your subsidy depended on where you were in terms of your percentage of poverty, and it was essentially between 100% up to 400% of poverty. To give you an example, a family of 4 at 400% of poverty is making around $90,000 a year. Clearly, their subsidy is going to be smaller than a family of 4 who's at around, you know, 105% of poverty. But still, that was the subsidy calculation. And so as we go back, 67% of Texas marketplace enrollees chose a silver plan. From folks that had financial assistance, so the bulk of folks were about 84% had financial assistance or purchased a plan with financial assistance, about 16% without. And so this goes through April the 19th, including special enrollment period, selection by age. And why is this important? Again, as we look at our 65 and older, 1% purchased the plan. But what's interesting here is, again, this millennial population, this young invincible population, in the numbers that signed up. I would also point out up here the 55 to 64 population, 22%, and the 45 to 54. Why is that important? Well, these are folks that are going to transition soon into Medicare. And so, meaning that oftentimes, and I see this as a practicing physician, and I practice, I'm an internist and a pediatrician, but I practice exclusively in the emergency department. I often have patients who may be 60 years old, have no insurance, have diabetes, hypertension, hyperlipidemia. They're getting the bulk of their care in the emergency department. It's Band-Aid care, essentially, because I'm not going to be able to manage their diabetes in a way that's meaningful. But as we're seeing these folks sign up, we're expecting also that once they reach Medicare age, the idea will be that they will actually be under a little bit better control of whatever chronic illness they have, and hopefully decrease the costs in the Medicare space as well. So more to come in terms of that. Not surprising that only 1% were 65 and older, but we were happy to see that the millennials, although they were not signing up in huge numbers, were still respectable in terms of how they were signing up. This is a breakdown by ethnicity for the state of Texas. So the Latino population, 171,000, the Anglo population, 192,000, African American, 70,000. And so, but there were still a large number that were either unknown or hadn't declared what ethnicity they were part of. Again, with regards to South Texas, where I practice in the area that I cover for Blue Cross Blue Shield of Texas, it's important for me to make sure that all our population signs up, but specifically that the Latino population signs up, since that is the bulk of the population in this part of the state. And this is a population that doesn't, all things being equal, even in the commercial space, does not sign up for insurance to the same level as African Americans and Anglos. And so in a company, if you offer insurance to an entire population, Latinos actually sign up by around 10 percentage points less than their African American and white counterparts. So that has a lot to do with the fact that many of our folks come from countries where commercial insurance is not the norm, where treating healthcare conditions tends to be more once you have a condition versus prevention. So there's a lot of education that we have to do, and the fact that we have a steady flow of recent immigrants, despite folks that have been here for a while, the acculturation levels change. And so educating folks about insurance, about preventative care, specifically the Latino population, is important, despite the fact that by and large they're a healthier population. So for coverage starting in 2014, the open enrollment period officially ended March 31st. For coverage starting in 2015, open enrollment period will be November the 15th through February the 15th. Again, only a 3-month period of time. However, folks can apply for Medicaid and CHIP at any point in the calendar year. And then members of Native American tribes can enroll any month, not just during open enrollment. And this is meaningful, especially, we don't have a huge number of Native American tribes in the state of Texas, but we do business in New Mexico and Oklahoma, where that is also going to be very, very important. It's just it's a different part of the law. Individuals for special enrollment period to switch their plan or pick a plan for the first time. We'll talk in a minute the special enrollment period. Special enrollment means if you have a qualifying event. So if you missed open enrollment and you need to make a change, you can do that during the special enrollment period, which was April 1st through November 14th. To be eligible, you have to have a qualifying life event during the past 60 days, and we'll talk about that in a second. And then you can enroll directly through any of the insurance companies that are participating in the healthcare marketplace. You may be able to get a financial assistance during this time as well. And if you have a plan and want to change it, you can do so in the marketplace through your insurance company, depending on where you first enrolled. So qualifying life events. You move to a new area that offers you a different plan that isn't covered by your HMO network. So let's say you have a network that is a little bit narrower, just in the region that you were initially in, but then you moved, let's say, to Amarillo, and your network is not active there. Well, then that's a qualifying event, and you can change your plan to get a network, so you'll have in-network benefits. You weren't married, you get married, you're able to have apply for insurance. You have or adopt a child, you lose the coverage due to job loss. So you lose your job and you lose coverage. So you were getting insurance previously through your employer, now you're uninsured, you can apply for coverage through the marketplace. You become a new U.S. citizen or permanent resident. Your income changes significantly again. Either you could have lost your job or taken a different job that paid less. So if that, or let's say the income was based on the family, the household, total household. You're married, and it's both spouses are contributing. One spouse loses their job, and now their insurance is unaffordable. They can potentially qualify for a subsidy. You can prove that your health insurance company violated its contract with you. You're no longer covered on a family member's policy because you turned 26, or you became legally separated, divorced, etc. You became a member of a Native American or Alaska Native tribe, you experience an error or other complication while trying to enroll. And so that's clearly in terms of folks that were having challenges with the website. In March, they could extend their enrollment period. So what if you don't qualify for a special enrollment? So if you missed open enrollment, you can get short-term insurance. That plan will keep you covered until the next enrollment period of November the 15th. And then depending on your income, you may qualify for Medicaid or CHIP. And that's also important. We saw clearly a lot of folks that qualified for Medicaid and CHIP that hadn't previously applied. So in 2014, the individual mandate went into effect. That's what we're talking about. Folks having to buy insurance. The healthcare marketplace was in effect. The essential health benefits, which we'll talk about in a minute. The fact that no pre-existing conditions, exclusions could occur. There were small business and individual subsidies. What's important is guaranteed issue. Guaranteed issue meaning that you could not be denied insurance, regardless of what medical problems you actively had or had in the past. Medicaid expansion occurred in some states, not all states. Clearly the state of Texas is one of the ones that did not expand coverage into the Medicaid space. And then the annual fee on health insurance or the tax changes. So what's going to happen in 2015 and beyond? So the employer shared responsibility reporting requirements will go into effect. Expansion of electronic medical records, the Independent Payment Advisory Board, small group market will be defined to increase in 2016. Employers up to 100 employees. So right now it was 50 employees. Large group would be 100 plus. The high cost plan excise tax. What's important for the Medicare population would be the Medicare Part D donut hole will begin to close, and I'll show you a graphic of what that's going to look like. And a few other things in terms of optimizing clinical outcomes. So, those are the three things that I really wanted to highlight, especially the Medicare donut hole closing, and then the fact that the essential health benefits, which is a reasonably rich plan, and the guaranteed issue. So just focusing on those, guaranteed issue, again, everyone is assured of getting health coverage, regardless of age, gender, or health status. And again, you cannot be canceled. And so we've had folks with active cancer who didn't have insurance who signed up, folks with HIV who signed up for insurance. The Medicare benefits remain secure, so Medicare covered benefits will not be reduced or taken away. So what you're hearing a lot of is, in the media that Medicare is being threatened. The individual Medicare benefits for actual people receiving Medicare is not in question. The idea is, what you're hearing is Medicare payments to hospitals may be decreased, not the benefits to individual beneficiaries. And the idea with the decreased hospital payments was that hospitals are currently getting subsidized extra through Medicare for uncompensated or charity care for your not your undocumented population, that population, but your uninsured population. So if the amount of insured folks goes up, then the subsidy that the government has to give hospitals can presumably go down. Again, depending on your network, you can choose your doctor. So there are a variety of different plans competing here in San Antonio with different networks, and really that's what you're getting from the insurance company is the network of providers and hospitals, as well as the care management and case management, et cetera, that the insurance company can provide. But it's important that folks check their network either before they purchase, if they have a particular doctor in mind, finding out if that doctor will be in that network. So hospitalization, there are 10 broad categories for what's considered essential health benefits. Hospitalization, clearly emergency services, laboratory services, maternity and newborn care. And so this is important because not every plan, a lot of folks think, well, maternity care was previously in every plan. Frankly, not every plan had maternity care, and women paid more for insurance for the risk of getting pregnant. For instance, a 21-year-old man and a 21-year-old woman, the woman before the Affordable Care Act, the woman paid more for insurance. Why? Because the man, there's no risk that he's going to get pregnant. The woman has a risk of pregnancy. And so that pregnancy, women were being essentially taxed more, even if they had no intention of getting pregnant. Mental health and substance abuse services. So again, not always part of every insurance plan prior to the Affordable Care Act, but now standard in every plan through the Affordable Care Act. Prescription drugs, rehab services and devices, again, not something that was standard necessarily prior. Preventative and wellness services and disease management. This is important. In order to promote prevention, it's important for folks to get out to see their doctors, right? So your premium through the Affordable Care Act has your preventative services already baked into that cost of your premium. Meaning, when you go to see your doctor for a wellness visit, you're not going to pay a copay at that visit. And if your doctor orders whatever is recommended on the U.S. Preventative Services Health Task Force, let's say, for instance, you're a 50-year-old woman who needs a mammogram, your doctor decides a colonoscopy is the right screening test for colon cancer, orders laboratory tests, may order an X-ray or an EKG, you're not going to have any out-of-pocket expenses for those tests because they're screening tests for prevention purposes, not diagnostic tests. And so that is probably the most, one of the most important and exciting aspects of the Affordable Care Act, and this is true also for Medicare beneficiaries. Ambulatory patient services, so your outpatient care. And then also exciting is pediatric care, including oral and vision care. So typically these are standard in Medicaid and CHIP products, but they were not standard in commercial health insurance. And again, to remind you, this is commercial health insurance. So clearly our company has, this is Blue Cross Blue Shield that you may be buying, or one of our competitors that you may be buying. A lot of folks think that it is the, quote, ObamaCare plan, which is the thought that it's a public plan that folks are purchasing. There is no public plan option. These are all private insurance companies that are doing business in this marketplace. It's not a public plan. So, list of the Medicare preventative services that are available, especially through Medicare Part D, and what's covered. A lot of folks are aware of the Welcome to Medicare prevention visit, but the yearly wellness visits, and as I mentioned, a vast array of preventative screenings that there will be no out-of-pocket expenses either through the Affordable Care Act or through Medicare. So one of the other things that the Affordable Care Act is strong to promote is coordination of care. And there are initiatives such as accountable care organizations and patient-centered medical homes or comprehensive primary care initiatives, et cetera, that are there to promote a holistic approach to patient care. Really the idea to transform the way that healthcare is being practiced in the United States from a reactive care treating acute conditions to a holistic preventative approach and working with your consultants in a patient-centered medical home model, and really going from the disincentive of keeping people healthy, which really is the case, because the more we do as physicians, the more we get paid. So if we do procedures, or we do a surgery, or we do this, or we do that, we're going to get paid more, versus we're not incentivized to keep patients healthy. So the idea is that if you are managing your population of patients and keeping them healthier, that you'll actually be getting paid more for doing that. And so what's being called in the industry value-based care, bringing value, true value in terms of monitoring the outcomes for your population. Individual physicians today may be lacking the tools to be able to do that, but those tools have been coming and are coming through EMRs and other electronic medical records and systems that are being put in place. and really bringing the idea of individual docs versus docs having to be employed. And nothing wrong with an employed physician, but especially here in the state of Texas, maintaining that strong independent physician and having independent physicians work together in collaboration to be able to manage their populations of patients. So we're excited to be able to participate in that here in the state of Texas. So I promised that I was going to talk about the donut hole and how that's going to decrease over time. So Medicare Part D prescription drug program. The idea that in 2013, the percentage you pay for brand name drugs in the coverage gap is right now close to 50%, 47.5%. And the percentage that you pay for generics is around 79%. By 2020, that will decrease to 25%. So 25% for brand name drugs and 25% for generics. And this slide shows you year over year what those percentages will continue to look like. What's significant is how the drop that will go from the 79% for generics to 25 over time. And so that will be of interest to our Medicare beneficiaries today, but really those folks that are going to get into Medicare in the future, because as we know, our population just ages every day, and we have more and more folks going into Medicare. So I talked about the additional Medicare tax. That becomes effective in 2013. That tax rate on wages increased for higher income taxpayers only. And then for Part B and D, the law freezes the income thresholds for the Medicare Part B and D program premium at 2010 levels through 2019. It also adds a new income-related premium for Part D. So clearly, the more money you make, the more than you would then pay in for that aspect of it. And the idea is, we see populations that are very discrepant in terms of their income in the Medicare space. And clearly, if you're making, $300,000 a year and you're 67 years old, then you probably can contribute a little bit more to some of your Medicare benefits than someone who may be making that $23,000. One of the things that Blue Cross Blue Shield of Texas is also committed to doing is guiding the newly insured. So I mentioned that I practice in the emergency department, and I see folks that are 40, 50, 60 years old who have never had insurance. And it's hard for a lot of us to imagine that, because maybe we've had insurance gaps in our lives, but most likely we've had insurance. I clearly have had insurance gaps, especially when I was younger in college and medical school. But I can't really imagine my life without health insurance. I can't imagine being 50 years old and never having had health insurance, but that's the reality for a lot of our folks out there. That's the reality for a lot of my patients as well. And so it's hard for us, who are reasonably sophisticated consumers of healthcare, to understand what a premium is, what a copay is, what coinsurance is, what a deductible is. Imagine being 50 or 60 years old and never having ever had to deal with those terms, just because you weren't insured. And so we're committed to being able to guide folks through that process. So during our open enrollment period, we had a big emphasis on educating folks around the Affordable Care Act. Now that open enrollment is closed and people have their insurance, we're educating about their insurance. What do you do now that you have insurance? What is this thing that's premium that you're paying monthly? And what, a lot of folks are like, well, I paid my premium every month. Why do I have to pay more money when I go see the doctor? And why do I have to pay money when I pick up my prescription? So the idea is that keep folks engaged in the system, make sure that they're optimizing their benefits. And we've been doing that through a campaign specifically called Now That You Have Insurance. And that's important not only for us to do, but for our entire community. So the idea is that if you're engaging with folks through your work that are new to insurance, don't take it for granted that they understand the system, that they understand that they have to pay their premium every month. Otherwise, they won't have the insurance later on. and trying to figure out what challenges they may have. Their insurance company, I can speak for Blue Cross Blue Shield of Texas, we have a variety of resources that are available for folks to be able to guide them through that process. So one of the things that we talk about is preventative care, so understanding that they won't have to pay any out-of-pocket expenses for their preventative care, the role of their PCP and how important that is, or the OB-GYN if the woman decides that she wants the OB-GYN to be her PCP. If they have an HMO, they understand the idea that they need to go through their PCP for a referral, the idea that they need to stay in their network in order to keep their own costs down. So for instance, if they decide to go out of network, they may not be aware that they're going to get balance billed for that discrepancy. Not by us, but by the provider, by the doc or the hospital, depending on where they decide to go. There's sometimes a lot of pitfalls in the process, so understanding that, check to see if your doc or that specialist or that hospital is in your network. Figuring out, that their doc or their specialist treat the condition that they have, and understanding some of the financial consequences. The list goes on and on. So we have a lot of information around that, and I think this is the type of information that folks that you may interact with may need as they move forward. For more information on where to get information on the Affordable Care Act, or now that you have insurance, we have it all here at the website above, bcbstx.com /health-care-reform. And so we have that information also in English and in Spanish with materials that can be downloaded in both languages. Clearly important here for the state of Texas. So these are the things that you'll find, things that you'll find on that website. What's important, I talked about tips for cost savings, and so we unfortunately see oftentimes, an example will be someone shows up to an emergency department, that doctor is out of network in that hospital, that member receives services there, goes home, and then gets a bill for a significant amount of money. And that hospital was out of network, that ER was out of network, and clearly you want to go to if you're having a true life-threatening emergency, you need to call 911 and go to the closest hospital, but oftentimes what we see in the emergency department are not true life-threatening emergencies. Then they're receiving a $5,000 bill, and they're wondering what was the point of having insurance, and we may pay what's a reasonable cost to that doctor, right? So not necessarily the $5,000, but what would be considered reasonable and customary since they were out of network. However, then the patient gets balance billed, and those are challenges that folks oftentimes face. And clearly with this population, especially folks that are kind of hovering over the poverty level, $5,000 might as well be $5 million, and they're not going to be able to pay for it. This is a list of other helpful resources that may be available. Clearly, Blue Cross Blue Shield of Texas, the Department of Health and Human Services, Healthcare Marketplace, the Department of Labor, the Kaiser Family Foundation. A lot of the slides that I showed you today come from that foundation. They have a wealth of information around the Affordable Care Act, a variety of ways to kind of navigate and mine information about the Medicare population as well. Civic Impulse uses govtrack.us to track legislation in the U.S. Congress, the Centers for Medicare and Medicaid Services, Medicaid, the U.S. Citizenship and Immigration Services. So we encounter this over and over again. Within the Latino population specifically, I mentioned that population has been slow to sign up for the Affordable Care Act on a national basis. One of the concerns is immigration. Latinos oftentimes live in mixed immigration status households. So where dad may be undocumented, mom may be a U.S. citizen, kids are U.S. citizens, they're concerned about giving their family information to the federal government for risk of dad getting deported. The administration has guaranteed consumers that this will not be an issue. Clearly, dad will not qualify for insurance in that way. However, he's not going to be at risk for deportation. Similarly, you might have, someone who is undocumented, someone who is a legal resident, and then the kids are U.S. citizens. And not only is that undocumented person concerned about their deportation, but that legal resident is concerned about losing their legal status by providing information that their spouse may be undocumented. And so we go around the state, parroting what the administration is saying, assuring consumers that this is not an issue, and I think we all need to be very conscious of that as we deal with the Latino demographic, not assuming that their legal status may be normalized, or if we're dealing with someone who has a normalized legal status, not assuming that everyone in the household has a normalized legal status. One of the things, this is my last slide, one of the things that I like to talk to folks about from a Blue Cross Blue Shield perspective is, oftentimes folks say, well, you're spending millions of dollars on these campaigns to educate the population. And we have our campaign, I didn't show it here, it's called Be Covered Texas. It doesn't have the Cross and Shield, it doesn't have the Blue Cross Blue Shield name. We don't sell through that campaign. It's clearly, it's just a public service campaign about the Affordable Care Act and educating folks. The reason we can do that is we're not a publicly traded company. We're not a private company. We're a customer-owned company. We started off as a not-for-profit here in the state of Texas over 80 years ago. Blue Cross Blue Shield of Texas is what's called a mutual reserve company. So we function on our day-to-day basis like a not-for-profit, but we have funds in reserve to be able to support our business. But the profits of our company get reinvested back into the company for the benefit of the individual consumer. So if you're a Blue Cross Blue Shield of Texas member, you're an owner of the company. And we're customer-owned, and so our fiduciary responsibility is not to Wall Street, it's not to stockholders, it's to you. And secondarily, it's to the state of Texas. So that's why we're in all 254 counties, because not all those counties are financially beneficial, but we are determined to be there as a public resource. Additionally, we see ourselves as a public health company. So a lot of the work that we do in the state of Texas is to promote public health and to really make sure that we're investing dollars in a way that's going to move the needle in public health. It makes good business sense. If we make our population healthier, we're making our members healthier, we're making the employees of our clients healthier, and it's kind of a win-win-win. And so when you look at us as a company, please look at us as a trusted resource. We're not in it to kind of fool anyone. We're really in it to provide information in a non-biased fashion and to educate folks to the best of our ability. Thank you so much for your time. Any questions?
Sentirme un poquito solo.